Well, good morning, everyone, or good afternoon, or good evening, wherever you may be. I'm very excited to welcome you as moderator to this really wonderful presentation on update on hepatitis B cure. My name is Debika Bhattacharya. I'm a professor of medicine at the University of California, Los Angeles, where I specialize in HIV and viral hepatitis co-infection. I am extremely delighted to introduce my friend and colleague, Dr. David Wyles, who will be presenting today. He is a professor of medicine in the Division of Infectious Diseases at the University of Colorado and is also the chief of the Division of Infectious Diseases at Denver Health Medical Center. His research interests include viral hepatitis, very relevantly, including the conduct of clinical trials with novel therapeutics for Hep B and Hep C, where he is a leader in Hep B clinical trials. Next slide, please. So these are the financial relationships with ineligible companies within the last 2 years of the board co-chairs and the board members. Next slide. And these are the financial relationships with the presenter, the moderator, and the planners and reviewers. A reminder that this webinar is eligible for continuing education credits. We encourage all of you to take advantage of this, including 1.25 CME credits and ABIM MOC points. We want to acknowledge the grant support of our Platinum supporters and contributors that are listed here. And just by way of introduction to navigate this activity, there will be poll questions during Dr. Wyles' talk. A separate window will show the poll question. Please choose your response for the poll, and the responses will be displayed after the poll closes. We also encourage questions. Many of you have submitted questions in advance of this webinar, but you can also submit questions using the Q&A button. We may not be able to address all of the questions in the time allotted, but we will try. Please do include your full name and institution. And the chat is open, and this is a great way for you to start discussion with other attendees, but please do not submit questions to the chat as presenter and moderator. We will only be monitoring the questions submitted to the Q&A. So questions to the Q&A, chat for everything else. Okay, and with that, I'll turn it over to you, Dr. Wyles.
Great, thanks, Debika. And thanks to IAS-USA for allowing me to do this presentation. I'm going to share my slides here. Okay, hopefully everybody can see that. Let me know if it doesn't look right. And we'll get into presenter mode here. And how does this look good to everybody?
Yep, it does now. Thanks, Dave.
All right, I had to switch them there. Okay, again, thanks, Debika, for the introduction. And I'm going to run through an update on hepatitis B cure. As you've already seen, these are my disclosures. And so these are our learning objectives for today. First, we're going to start off by describing the current indications for and approaches to hepatitis B treatment. We're going to talk about the mechanisms with different approaches to hepatitis B cure, and then highlight some of the progress and limitations that we've seen thus far with current hepatitis B cure trials. We're going to start with a pretest question. Which hepatitis B virus test or disease stage parameter is not part of updated hepatitis B treatment guidelines, specifically those from 2025 for the European Society for Study of Liver Disease or the 2024 WHO updated hepatitis B guidelines? You can choose here hepatitis B DNA, E antigen, fibrosis stage, or ALT. Okay. And we'll move on. We've got another pretest question. So which of the following is not included in functional cure of chronic hepatitis B virus infection? So which is not part of the definition of functional cure? Loss of hepatitis B surface antigen sustained for more than 6 months off therapy. Undetectable serum HBDNA levels sustained for 6 months off therapy. Clearance of HBV covalently closed circular DNA or cccDNA from hepatocytes, undetectable hepatitis B e antigen levels. Go ahead and answer, and then we'll come back to these questions at the end. So to start, I just wanted to set the stage with a little bit of an update on global and US hepatitis B epidemiology, and most of this data is as of 2022. And so first you can see from the WHO in 24, a kind of a global heat map, if you will, of the prevalence of hepatitis B. Over here on the left, you can see in total, there's about 250 million persons estimated to be infected chronically with hepatitis B. And by the numbers in the different regions, you can see most of the disease burden actually lies in the Western Pacific and Southeast Asia region, as well as Sub-Saharan Africa. The United States and the Americas are a lower prevalence area, and we'll talk a little bit more about that in coming slides. I want to highlight that there's over 1 million deaths a year due to hepatitis B, a lot of that due to HCC and cirrhosis. And we'll come back to kind of where we are currently on our kind of goals of treatment and diagnosis. So as many of you are, I'm sure, aware, there are ongoing efforts for hepatitis elimination across the world, both for hepatitis C and B. And what I'm showing you here are kind of the goals for combined, looking at all chronic viral hepatitis C and B as of 2030 to get 90% diagnosed, get a 90% reduction in incidence or new infections. And that actually is the one parameter that's different by hepatitis C versus B, where the goal for hepatitis B is a 95% reduction in incidence. That higher goal reflects the fact that we have an effective vaccines or multiple vaccines for hepatitis B. Then to get 80% of those with chronic infections treated. And if you do kind of these other things, you will see this reduction in mortality. To look a little deeper here, focus on the red arrows, which is kind of the current status, at least as of 2024, which are from WHO, is only about 13% of persons globally with hepatitis B chronically are diagnosed, and even lower, only 3% are estimated to be on treatment currently. Part of that is due to older treatment guidelines, which were somewhat complex, and we'll talk about how those are evolving as well. So if we now take a look at the United States hepatitis B epidemic, first, what you can see here is data from CDC on the left of new infections or incident acute hepatitis B infections. And the blue bars represent the estimated number, whereas the orange line across here are the number that were actually reported to CDC. And then from that, they estimate the number of new infections per year. And what you can see is they've remained relatively low and actually slight decreases in the last 2 years that are noted here in 2020 and 2021. For the year of 2021, about roughly 2,000 cases reported to the CDC, which extrapolates to about 13,000 estimated acute infections. There is a difference in chronic hepatitis B prevalence in the right figure. When you look at populations and compare persons living with HIV versus those that are not, the prevalence is significantly higher in persons living with HIV. About 8% roughly of persons living with HIV are estimated to be co-infected with hepatitis B, reflecting common transmission modes. And then if you look at the US as a whole, somewhere around 1.7 million persons are estimated to be infected. That prevalence is significantly higher in persons who were born in other countries and have since moved to the United States. You can see here, persons born and raised in the United States, 0.15% prevalence of chronic hepatitis B, where it's over 1% in those that were born in other countries. And then coming back, one last fact about persons living with HIV. Overall in the United States, it's somewhere around 100,000 are estimated to be co-infected with hepatitis B. So I want to spend just a little bit of time kind of level setting and talking about the different hepatitis B markers we have that we use clinically. These often cause a lot of confusion, so I think it's worthwhile. So what I have listed here are what I consider the initial tests. If I'm seeing somebody in clinic and we're going to screen for hepatitis B, I typically get all 3 of these tests. We start with the hepatitis B surface antigen. So this is a viral antigen. It is present in active infection. It's kind of the signature marker of active hepatitis B infection, not necessarily chronic infection, but active infection. Chronic infection then is this antigen is positive over a 6-month duration. So you have 2 consecutive positive surface antigens over 6 months apart. I'll just mention this briefly and we'll come back to it during discussing cure, but quantitative tests are available. So not only just yes or no hepatitis B surface antigen is present, but there are tests that give you an actual amount of surface antigen present in blood or serum. These are not used very routinely right now, but they do predict the success if you happen to try to stop nucleosides in somebody that's been on them for a long time. If you have a low level before you stop, they are more likely to be successful with that. And then as I'll show you in current cure studies, it certainly does predict response to some of these novel therapies. Hepatitis B core antibody, there's a total and an IgM. The total antibody, this test reflects, has the patient ever been infected with hepatitis B? If the core total antibody is positive, they've been infected at some point in the past, or at least that's the majority. We'll talk about some other possible indications. So again, indicates prior infection. There is an IgM. Generally, for most folks, I'm only interested in the core total unless it's acute hepatitis where I really want to know they have acute hepatitis B infection. Then you might check an IgM. And then hepatitis B surface antibody, this is the marker of immunity. So this can be present in somebody either due to past infection that the immune system has responded to, or to vaccination. And the differentiator between vaccination is the core antibody total. That won't be present in somebody who was vaccinated. It will be present in somebody who was infected, even if they have surface antibody detectable. And this is a quantitative test, and I think we're going to start paying more attention to that quantitation. Anything above 10 is considered protective or an adequate response, but certainly higher is better in terms of predicting durability of immunity. So just schematically to show kind of how some of these markers evolve. So when somebody becomes acutely infected and has a self-limited disease, their immune system mounts an effective response and they don't develop chronic infection, that's the scenario on the left. So surface antigen comes up, the immune response kicks in, core antibody comes up, and the surface antigen goes down and eventually is lost within 6 months after the exposure. And then you develop surface antibodies, the anti-HBs later. And you will potentially have E antibodies as well, but those can wane over time. And your core is positive, reflecting prior infection, but not active. The difference with somebody who develops chronic infection is on the right. And here the main difference is you can see surface antigen comes up and is never lost because they have chronic infection. The immune response has not been effective in clearing the infection and maintaining immune control. They do have core antibodies, but you also notice they don't have surface antibodies. So those are kind of the hallmarks in the evolution of initial infection and serologies. So how do we interpret the serologies? This is a question that comes up repeatedly from fellows, from colleagues. How do I interpret my hepatitis B testing? I'm not going to run through all these. The one I want to spend time on is this, which is the isolated core positivity. So this is total anti-hepatitis B core antibody positive, not the IgM, but the total, essentially IgG, whereas your surface antigen and your surface antibody are negative. There are a number of possible, and this is interpretations, this is from the CDC. What we think is most common is that this patient actually has resolved infection. They were infected with hepatitis B, they've resolved, and now enough time has just passed that their surface antibody titers have just naturally kind of gone down to where they're now below the quantitation that we would consider protective, less than 10. So in that case, you know, it's past infection, but not active hepatitis B infection because the surface antigen is negative. Now there is a cult infection where surface antigen is negative, but there actually is active viral replication. Doing a hep B DNA would be the way to determine this. This third option is the last one I really want to mention, but we see this relatively frequently, actually. Persons who have had passive transfer, and I see it in immunosuppressed patients where they get immune globulin for one indication or another. They previously were tested, their core was negative, now it's positive, but their surface antigen is negative, and it causes a lot of consternation. So you can get passive hepatitis B core total antibody. So we did the initial serologic testing, and now what is some follow-up testing? And so this slide really pertains to those who are surface antigen positive, and really in particular those that are chronically surface antigen positive, so have been surface antigen positive for more than 6 months, and now we're calling them chronically infected. That's where testing for hepatitis B e antigen comes in, and traditionally this has been done in really everybody. The e antigen is another viral antigen. It's a surrogate for viral replication, can become negative during the course of infection, and we'll talk a little bit more about that. And traditionally, this has been a key component of treatment algorithms. You had e antigen positive versus e antigen negative chronic hepatitis B. And depending on that e antigen status, there were different viral load cutoffs for starting antiviral therapy against hepatitis B. And what I'm going to highlight in the coming slides is that this has really been removed now from updated guidelines in an effort to simplify them and make it more straightforward and maybe easier to decide if somebody should be on therapy. That has been thought to be one of the barriers to getting people on hepatitis B therapy, is it was too complex. And there also is hepatitis B E antibody. This does go into the definitions of kind of what phase of chronic hepatitis B they might be in. And then, of course, hepatitis B DNA. All of you are familiar with monitoring HIV RNA as a marker of therapeutic efficacy. So again, for hepatitis B, this is now widely available. It defines active viral replication, and it is a key component of treatment criteria. What that level of DNA is will help you determine whether somebody should be on therapy. So phases of chronic hepatitis B. Hepatitis B is actually very interesting, very complex, and it's not necessarily the same in each host, and it evolves over time within a host. So after somebody's infected, particularly if you talk about vertical transmission where there's infection either in the peripartum period, in young children who are infected, the immune system normally doesn't develop much of a response, so they have normal transaminases. They wouldn't have fibrosis or inflammation on a biopsy, but they have very high levels of hepatitis B DNA and very high levels of e antigen. So this used to be called immune tolerant chronic hepatitis B. The terminology has kind of evolved. Now we really just say chronic infection. And the differentiation here is we're saying infection versus chronic hepatitis because there is no hepatitis. There is no liver inflammation. And that's depicted here at the left. So the immune system's not kicking in. It's kind of saying, I don't care about hepatitis B, and there's high levels of replication. At some point, usually during adolescence, young adulthood, again, this is the vertical transmission case, there's a shift. The immune system starts to react. Now we call it e-antigen chronic hepatitis because there is inflammation. The transaminases are high. There's inflammation on biopsy. The DNA levels of hepatitis B are still high, but they're lower than the immune tolerant phase, what used to be called immune tolerant phase. And again, this used to be called immune active chronic hepatitis B, now just chronic hepatitis B. And then from there, the immune system can kind of take further steps where you actually lose e antigen negative, and become e antibody positive. This is what we used to refer as the inactive carrier state. The DNA is typically very low, can occasionally be undetectable, usually low, like in 1,500 range. And the transaminases are normal. The immune system has kind of kicked in and been effective. This is not a permanent state, however, for a lot of people, and then they can go on to either revert back to e antigen positive chronic hepatitis, or sometimes go on to actually fully clear hepatitis, where they would lose surface antigen, become surface antibody positive, and you can go back and forth between these stages. Long-term e antigen negative chronic hepatitis B, where the transaminases are up, but the e antigen has remained negative, is kind of the long-term evolution of chronic hepatitis B in patients, and is a more severe form of disease where now patients are going to be more likely to have complications such as cirrhosis or HCC. Just two slides, well, three slides actually, just to emphasize the role of hepatitis B DNA in the pathogenesis of disease. This is a classic old figure, just really showing a direct correlation between time to progression to cirrhosis and higher viral loads. Going from the low here, less than 300, to over 1 million, you can see a much higher rate of progression over a decade plus to cirrhosis. So much like we think of HIV, the higher the viral load for hepatitis B, the more aggressive the disease course is, the faster the progression. This is from Taiwan and the REVEAL study, really showing the same concept, now looking at both cirrhosis and hepatocellular carcinoma. This was a prospective study, so a little stronger methodologically, but again, showing this correlation. The higher the viral load goes, the faster the progression, or the higher the incidence of cirrhosis in this case, and the higher the incidence of hepatocellular carcinoma. So again, reinforcing this direct link between HBV viral load and disease progression. And finally, you noticed in both those studies, they kind of set the lower number at 300. This was data from now a few years ago from the NA Accord study that Nina Kim presented and has since published, looking at incident hepatitis hepatocellular carcinoma in persons living with HIV. And I think the real kind of take-home point from this was that even those, when you just looked at a split between above or below 200 copies of DNA, so a really pretty low level that traditionally had not been thought about as where you would step in for therapy, even anybody that was just above 200 had almost a 3 times, over 2.5 times increased risk of developing HCC. And you can see, again, it really follows less than 200, but even 200 to 2,000, almost a doubling in that risk. So this low-level viremia really still having a significant clinical impact. And it's been studies like this that over years now have finally come to influence our treatment guidelines. So I want to talk about current therapy. The 3 agents highlighted here in the red box are really the main agents we consider using currently for hepatitis B therapy: entecavir, and then tenofovir, 2 different forms of tenofovir disoproxil fumarate or tenofovir alafenamide. These are the dosings, obviously, if you're treating hepatitis B alone. All of these agents, including entecavir, have HIV activity, so you would never want to use these agents alone. In a person that's also living with HIV and hepatitis B, they would be, obviously both forms of tenofovir are components of current modern first-line antiretroviral regimens, and so they would be incorporated in, whereas entecavir is a standalone therapy. So again, this discussion and thought about we need to simplify hepatitis B treatment approaches is not brand new. This is something Nora Turow mentioned back at AASLD 3 years ago. And looking at different components, one, we need to really get away from risk-based screening to think about universal screening for hepatitis B. We need to kind of simplify treatment, and we'll talk more about this in the way it's judged and how we think about who should be treated, and really focusing on the DNA levels. Hopefully with these last few slides, that's been reinforced about what a key component that is for disease progression. And then in patients with advanced fibrosis or cirrhosis, really we should be treating everybody for hepatitis B, and we'll come back to these. So I updated this slide to show some kind of modern HBV treatment algorithms. AASLD, I think, is in the process of updating, but the last real formal treatment guidelines released were from 2018, and I kept those in there to highlight kind of what the old status was. Whereas here you see it's complicated. You need to know e antigen status, and whether you're e antigen positive or negative, the DNA thresholds vary. Even if you had moderate fibrosis, they use different thresholds. Whereas cirrhosis, they didn't really address, subsequently now we've really come to say for anybody with cirrhosis, everybody should be treated. So I want to highlight the EASL 2025 guidelines, which were just kind of released at the International Liver Conference, and then the WHO 2024 guidelines. And what you'll see is e antigen status has been removed. And it really focused, is the ALT abnormal? Not 2 times the upper limit of normal, not 1.5, just is it above the upper limit of normal? And in that regard, I'll draw your attention down here to the bottom that what your lab parameters say in your local EHR, electronic medical record, may not really be kind of accurate. And at least AASLD recommends using an upper limit of normal for ALT of 35 in men, some would say even 30, and 25 or 20 in women, depending on which guidance you look at. So one, keep that in mind. And so if you have an abnormal ALT and a DNA above 2,000, regardless of e antigen status, EASL would say you should treat. Or you can look at even if the ALT is normal and they have other criteria, including immunosuppression, a high hepatocellular carcinoma risk, which we'll talk more about, HIV, hepatitis delta, co-infection, other criteria, even if their ALT is normal, they should be treated if their DNA is above 2,000. And then EASL says anybody with significant fibrosis, so more than F2 fibrosis and a DNA above 2,000 should be treated, or anybody with cirrhosis, as long as there's any detectable level of hep B DNA, should be treated. WHO is even more permissive, if you will, about treatment. So abnormal ALT and DNA above 2,000, so they combine those. And the difference is they say, or other criteria. So you don't even need a DNA above 2,000 if you have these other things like a high hepatocellular carcinoma risk, immunosuppression, hepatitis delta, et cetera. And then they lump moderate fibrosis with cirrhosis or advanced fibrosis to say retreat regardless of ALT and essentially regardless of DNA if it's detectable at all. Okay, so that's kind of our overview of the current status of hepatitis B and treatment approaches. So now we'll take the rest of the time and talk about where we are with cure. And we're going to start with how do we define cure? So most of the time when we're talking about cure of hepatitis B, we're talking about a functional cure. As I put here, immunologic control. The components of that would be an undetectable hepatitis B DNA, loss of E antigen and surface antigen, and that's sustained for 6 months off therapy. Whether you actually have surface antibody appearing is kind of variable as whether it's used as a component. It's not a criteria typically to judge cure, although most patients or trial subjects who do develop a cure or meet the other criteria will have detectable surface antibody, but it's not universal. And inside the liver itself, there will still be cccDNA present, and there will be integrated HBV DNA. We're not addressing those in a functional cure approach. Now, a sterilizing cure, kind of maybe the holy grail, if you will, really means you're eradicating hepatitis B entirely from the host. So you have all the other 3 components we talked about, but now when you look inside the liver, if we could do that, or you did a biopsy, you wouldn't see any cccDNA. So there's none of this episomal HBV DNA hanging out. And actually, you could extend that to say even within the chromosome, there's no integrated HBV DNA. That is really not being targeted with our current cure approaches, a sterilizing cure. This is from a recent review that Jordan Feld and colleagues did, just kind of schematizing what we just went through. So you have the chronic infection. You first come in with replication inhibition, which we already do with nucleoside analogs. They don't do much of anything to surface antigen. So now most of our cure therapies are focusing on ways to reduce surface antigen. And we'll talk about those. Bringing down surface antigen, in theory, may allow the immune system itself to kind of wake up and be reinvigorated and respond to some extent. That's not been terribly successful alone. And then where cure strategies have now evolved, I think, is not only surface antigen reduction, but now adding in some other type of immune stimulation. So actually trying to boost the immune responses to allow us to get to this functional cure status where surface antigen, that's the functional cure. And then again, sterilizing cure is where we get rid of all traces of hepatitis B within the body. I don't want to spend a lot of time on HBV virology, but I want to highlight some key components that apply to cure approaches. The first is the schematic of hepatitis B. So hepatitis B is a DNA virus, but there is a pre-genomic RNA intermediate. And what this is showing you is when the proteins are translated, so you get transcription from DNA into RNA, and then that RNA goes to a ribosome and is made into a protein, or what we call translation. And that translation is the generation of the proteins, is all done off the same sequence for the different viral proteins. The way you get different proteins is it just starts reading in different points, if you will. And what's unique about hepatitis B in our current cure strategies, if you target this proximal part of the hepatitis B X protein reading frame, you actually overlap with the reading frames or the translation of all the other proteins. So just targeting in this area, you're going to knock down all the viral proteins. I think that's one very important aspect, and we'll show some more of that later. And then with the life cycle, there's lots of opportunities to intervene. Entry inhibitors we have examples of. We're not going to talk much. We'll talk very briefly about those today. They're also applicable to hepatitis delta. And then transcription inhibitors, so affecting cccDNA going into RNA. We have RNA silencers, which we'll spend a lot of time talking about, and then capsid assembly. So the core kind of capsid protein that encapsulates the pregenomic RNA, where it's initially can be packaged and then sometimes reverse transcribed into DNA. We do have very exciting, I think, small molecule inhibitors of capsid formation and recycling of that back into the nucleus to replenish cccDNA. So this is an audience response question. Which of the following is not currently under investigation in humans as an HBV cure strategy? CRISPR-Cas9 degradation or excision of cccDNA and integrated HBV DNA, siRNA, small interfering RNAs or antisense oligonucleotide-mediated degradation of viral RNAs, small molecule modulation or inhibition of capsid assembly, surface antigen depletion by monoclonal antibodies, or immune modulation augmentation through different mechanisms, including TLR8 agonists or exogenous interferon. So please go ahead. Okay. And now we're going to talk about kind of an overview. Oh, here's our results. Okay. Um, so a pretty even split between a lot. A third said CRISPR-Cas9 is not, and then a third said surface antigen depletion by monoclonal antibodies. And so we'll hit this, but CRISPR-Cas9 is really very much still experimental and in preclinical models in general, especially for hepatitis B. So that's the area that is not really under active investigation in humans. Again, there are in vitro studies and other things ongoing, but not really in clinical trials for hepatitis B. So here's our overview. We can target the virus or immune-based therapies. And I'll just leave this here and you'll have this to see. I'm not going to run through this now because we'll hit most of these mechanisms as we talk about specific studies. So a second response question, the rate of functional cure, and we've kind of defined that, but loss of surface antigen and undetectable hepatitis B DNA maintained off therapy for 6 months. After 24 weeks of Bepirovirsen, which is an ASO, an antisense oligonucleotide, is about what? Do we get 90% functional cure, 75, 25, 10, or no functional cure has been seen thus far? Okay, let's see what we've got. So we've got optimists is what I would say here. So the most popular answer was 75% rate of functional cure by 45% of folks. As you'll see, it's much closer to 10%, probably actually a little bit below 10%. And that was only put in by 11%. So let's look at the data. So Bepirovirsen, again, this is an antisense oligonucleotide. So this is actually an RNA DNA hybrid oligonucleotide. As I alluded to before, and you can see in the schematic here, this shows you exactly the sequence where this ASO works at the beginning of the X protein open reading frame, but it hits all the different viral proteins. So you hit all the RNAs for degradation, which then in turn affects all the viral proteins. So you're getting core, surface antigen, and polymerase as well. One of the unique things about ASOs that I'll talk a little bit more about in the coming slides is these are not hepatocyte targeted per se. So they're taken up by non-hepatocyte liver cells in particular. So this is Kupffer cells or macrophages. And it turns out, I think what is really a key component of their activity is that they turn out to be toll-like receptor, specifically TLR8, stimulatory molecule. So you get not only a direct antiviral effect through the ASO and RNase H-mediated degradation, but you're getting an immune boost as well. And so this is one of the phase 2 studies that was published in New England Journal. And there are 4 groups. I'll just highlight group 1 and group 2 were both that got 24 weeks of the ASO therapy. It's a subcutaneous injection weekly. Group 1 got 300 milligrams the entire time. Group 2 started off at 300 milligrams for 12 weeks and went down to 150 milligrams for the second 12 weeks. And what you can see here is the primary outcome here was essentially a functional cure, although they remained on nucleosides if they were on them when they started. So not complete, but remained on nucleosides, but otherwise 6 months off Bepirovirsen, what proportion had an undetectable surface antigen and DNA? And you can see here it was right around 9 to 10% in those groups. So that's where we get that figure of about 10%. I just want to come back to this concept of maybe that ASOs are more potent because they have a dual mechanism of action, immunostimulatory as well as targeting hepatitis B RNAs for degradation. So GSK 404 is an siRNA, so a small interfering RNA. And it is conjugated to this sugar and a galactositamine that makes it targeted to the liver. So it's specifically, those essentially engage with receptors on the hepatocytes, and this siRNA is then brought into hepatocytes. So they reach much higher levels inside the hepatocyte, but don't get to those non-liver cells we talked about that Bepirovirsen does, where you get TLR8 stimulation. And these are the exact same actual sequence they're targeting. And what you can see is with an siRNA, even a liver-targeted one, you get less than a log decrease over about 12 weeks here, just numerically. about 0.75 to 0.44 log decrease. Whereas Bepirovirsen, these are the curves from that phase 2 study in New England Journal I showed you in an earlier study where it was just given 6 doses over 4 weeks. You get 2 loading doses and then 1 over the next 4 weeks. You got about a 1.5 to 2 log decrease. Again, the exact same sequence, but different delivery methods, with ASOs having an immune component to their mechanism, I believe. So ASOs at least look a little more potent in isolation. So we talked about the end of treatment, 24 weeks off treatment from the Be Clear study. What was then done is those patients were eligible to enroll in a longer-term follow-up called Be Sure. And I'll remind you again, complete response was considered surface antigen less than detectable and DNA below the lower limit of quantification. There was this partial response where surface antigen was less than 100, but not undetectable, and DNA was still suppressed. So they went through the Be Clear treatment 24 weeks. They were monitored 6 months off. If you still had a complete or partial response, they could enroll into this Be Sure study over a 3-month period. Once they got into Be Sure, they were monitored for the first 3 months. And again, if this response was maintained, then they could actually stop their nucleoside analog. So they could stop their tenofovir or entecavir. And then they were followed. And what I'll just show you is, so you had complete responders here. Of those, some didn't want to stop their nucleotides or withdrew from the study, but of those, there's only 10 patients that stopped. And then 6 months later, 8 of those 10 maintained that functional cure definition, now off any type of hepatitis B therapy. And what I'll just point out is if you attained that, it was 80% of those that stopped, then it was durable out to a year and a half. 24 months after they stopped, but a year and a half. And so it's very durable, but you might lose another 1 or 2% in that nucleotide stopping. The partial responders was not nearly as durable. You can just see here only about a quarter maintained a durable response once they stopped nukes. And again, they already did not completely suppress surface antigen. So that's really not a group that would widely be considered to stop nucleosides. So we showed the studies. Now, this is a follow-up study, I think a natural kind of evolution. So we have those responses from the phase 2 24-week treatment arm. Is there anything we can do to decrease the relapse rate, essentially? I didn't highlight it, but at the end of the Be Clear study, about 40% of patients at the time they did their last injection of Bepirovirsen had a negative surface antigen and a negative DNA. So it went from 40%, and ultimately you had over a 50% relapse rate, getting down somewhere to 10% response. So this study looked at, you do the Bepirovirsen, and I just showed you one of the treatment arms for 24 weeks down here, and you can see this dark blue bar as it increases. At the end of 24 weeks of treatment here, again, about 40% have a negative surface antigen and DNA. And now instead of just stopping all therapy, they went on to interferon. So this was sequential therapy going from ASO to interferon maintenance therapy given for another 6 months, so a year of therapy total, and then stopped to see long-term maintenance of response. And what you can see is as soon as they switch to interferon, you already start to see relapses occurring. And then after interferon is stopped, a little bit more relapse. So ultimately, when you get down to the end here, this showed 13% in this arm. Overall, it's really right back about down to where it was from the original study that didn't have an interferon chaser, if you will, about a 10% durable response, maybe slightly higher. These different bars in this left-hand graph just reflect the responses by baseline surface antigen. So if they're less than 1,000, these are these light blue bars. So again, lower surface antigen does have better response. Although the durability doesn't seem to be a lot different. You had a higher response at the end of treatment, so you still lose responses about 50%. But overall, it's higher. And then the gray bar is those that were less than 3,000 when they started Bepirovirsen, and then the darkest blue bars are the whole cohort, regardless of what their surface antigen was. So again, baseline surface antigen quantitative certainly predicts responses, but it doesn't really seem to predict relapses necessarily. So that's Bepirovirsen, and we'll come back to it, but that is now into phase 3 studies that are active and ongoing. Bepirovirsen is kind of the first ASO. We saw at the European Liver Meeting some what you would call next generation antisense oligonucleotides. This is from Osper Biosciences. This is, ASOs are like any other drug. There are modifications you can do to alter the distribution, make it maybe more specific, and avoid off-target effects. And so with modifications, I pointed this out. This is, again, 24 weeks of a weekly subcutaneous injection. In a population, this was an e-antigen negative group. But what I'm highlighting here over here, so these green bars are at 24 weeks, so the end of treatment, the proportion that had undetectable hepatitis B surface antigen. You can see it's 75%. So again, we can't compare directly. With Bepirovirsen, that trial included a wider range of baseline surface antigens and e-antigen positive and negative, but was about 40%. So now we're seeing 75%. And then these two percentages are the difference between those less than 1,000 versus above 1,000 below. The 73% is those with a baseline surface antigen above 1,000. So you're also seeing less of a difference based on baseline surface antigen, presumably because it's a more potent ASO. It also has been optimized to try to induce TLR8 signaling. And then a concept I just want to point out, and something we have to kind of get used to, as you're looking at hepatitis B cure trials, we have to be okay with seeing ALT or liver enzyme elevations on therapies. And it most of the time is not necessarily at least a toxicity of the medication. It's a marker of the immune response kicking in. And so what this just shows you here, this top is an example of one patient that had a quick surface antigen decline, and then in orange is their ALT. So you see this really high ALT flare up to 800 of ALT, then quickly coming down, and followed by a functional cure with appearance of surface antibodies. So in this case, that flare is a marker of actually immune response, not a toxicity per se. And the bottom kind of heat map here just shows the more surface antigen decline you have, the more likely you are to see ALT flares. So now I'm going to quickly go through some other studies. This is a study called the IMPROVE-1 study with an siRNA, imdusiran. You can see that by the last letters there. siRAN is kind of the signature in naming for an siRNA therapeutic. So this was given as injections every 8 weeks. So that is a big difference. siRNAs can be given much less frequently than ASOs. And then this study started with a lead-in with siRNA every 8 weeks, and then randomized patients to continue with siRNA with interferon or interferon alone, and different durations, 16 or 24 weeks. What you can see is functional cure rates are somewhat similar to what we saw with the ASOs, but now looking at a longer duration one and addition of interferon. But these are small numbers, so one patient either way will really affect the percentages, but we're in the range again of 10 to maybe 20%. I wanted to highlight this from this table just to draw your attention to their baseline surface antigen. And what you can see is that almost all these participants started with a surface antigen that was less than 1,001. So reinforcing that concept of a lower baseline surface antigen is going to respond better to novel cure strategies. And then show you that surface antibody, almost all of them develop surface antibody, some at very high titers during the course of therapy with their functional cure. I also included this for what's down here on the left. This study incorporated a kind of next generation surface antigen assay that has a log more sensitivity. So instead of going down to a lower limit of detection of 0.05, it went to 0.005. And there were participants who relapsed that you could see either they never suppressed surface antigen by this very sensitive assay, so it kind of predicted relapse, or it appeared earlier than the standard surface antigen assay. So I think we'll see maybe more of this. We'll see if the definitions evolve, or this is used as another kind of predictor of whether you could maybe stop nucleosides or whether somebody would relapse after investigational therapies. This is the IMPROVE-2 study, and I want to highlight this because now we're bringing in other immunomodulatory approaches, so therapeutic vaccines and PD-1. So programmed death receptor 1 is a marker of immune exhaustion, and if you inhibit that molecule and ligand interaction, you can again potentially invigorate immune responses. So again, we're using the same siRNA with a lead-in every 8 weeks of 4 doses, and then these groups were randomized to different interventions. Some continued, were given after the siRNA lead-in, they were given a vaccine. So this is a chimp adenovirus and a modified vaccinia ankara are the two different platforms. And this is VTP-300, which is essentially a consensive hepatitis C genotype coding sequences. So it has core, polymerase, and surface antigens in there in this vaccine. And so some groups were given vaccines, some were just stopped and given placebo. And then one of the groups down here in brown, in addition to getting both vaccines, also got the anti-PD-1 therapy, nivolumab, to hopefully invigorate or stimulate immune responses. And so you can see here one just graphically on their surface antigen response. The red group here got placebo, so no vaccine, and they saw their surface antigen come up and be higher after just the siRNA. Where all the groups that got vaccine, there's some at least hint or suggestion of vaccine, either making a little more surface antigen suppression or keeping it durable. And then again, the bottom line here is the group that got all three. They got siRNA followed by the vaccine, and with the last vaccine dose, they also got anti-PD-1 therapy. These percentages down here, this first percentage is the percentage that were eligible to stop nucleosides. And so you can see, again, all the groups that got vaccination or vaccination with PD-1 had higher rates of eligibility to try to stop nucleosides. And then the second percentage are the percent that had to go back on their nucleoside because they failed. And so a lower failure rate compared to that placebo group, or 40% of those who stopped had to go back on. The last thing I'll point out here is down here in these triangles. The only 2 patients in this trial that experienced a functional cure were in the group that got everything, got siRNA plus vaccine plus anti-PD-1. 2 participants in small numbers, can't really draw a meaningful conclusion, but perhaps suggestive. So this is another study looking at siRNA again, and now this is tobevibart, is a monoclonal antibody targeting surface antigen. So it's a humanized monoclonal antibody that's injected or given subcutaneously that binds to surface antigen and will remove it from circulation, essentially. Will also act as an entry inhibitor since it targets surface antigen and blocks it from its receptor. And then it may also even have a vaccinal component where it binds surface antigen and presents it to antigen-presenting cells. And so this study looked at the monoclonal antibody to surface antigen alone with an siRNA or with an siRNA plus PEG interferon. What you can see with surface antigen depletion alone by an antibody, you don't see any responses at end of treatment with loss of surface antigen. You see more responses with the combination siRNA plus the surface antigen targeting antibody. And then finally, adding an interferon, you see even higher responses. The 2 percentages are whether they were below 1,000 or above 1,000. So you see a really big difference, those below 1,000 surface antigen at baseline having better responses. I think this is our last kind of study looking at siRNAs. I'll put this in here because this includes another immunostimulatory product. This is an immunotherapeutic, BRI-179, which essentially has all the forms of surface antigen in a virus-like particle that's given as kind of a vaccinal component. But it includes the large surface antigen, which there aren't a lot of natural immune responses to, so maybe not already exhausted. The thing I want to point out is, so this study looked at those as participants who had previously had this kind of vaccine-like therapy, and then gave them siRNAs with interferon. And what you see, if they'd been previously vaccinated with this surface antigen, essentially vaccine, they had faster or steeper declines in surface antigen with siRNAs. And then specifically, if they showed response in that prior trial, making surface antibody, they had much higher levels of response to losing surface antigen or losing surface antigen with high titer surface antibody than those who had gotten that prior vaccine but did not respond. And about 60% overall in that initial vaccine trial had responded. So again, another suggestion that immune modulation is going to be a component, I think, of cure therapies going forward. Okay, in the next 5 minutes, because I want to leave time for questions, I want to talk about CAMs, or capsid assembly modulators. The way they work is they actually enhance or more rapidly cause the capsid to form, and it forms so fast, essentially, you can think about there's not time for the RNA, pregenomic RNA to get packaged. So you get empty capsids. And so one, you inhibit viral secretion, but you also prevent this recycling or replenishment of pregenomic RNA going into the nucleus to replenish cccDNA. I would say one of the leading next stage compounds is this ALG-184. It's very potent. What here you can compare just in the blue line combination therapy, entecavir plus ALG-184 to entecavir monotherapy. So you'll see a faster HBV DNA decline. And then at higher doses of 300 milligrams in the bottom right here, I just want to allude to the fact that this actually, you can see surface antigen decrease, about a log decrease over 6 months with the higher dose of ALG-184, presumably due to inhibition of recycling of pregenomic RNA back into the nucleus and inhibiting some level of cccDNA replenishment. And that second mode of action really seems to depend on the level you achieve, particularly the trough concentration, and that's why the 300 milligram dose, most of the responders here had quite high trough concentrations. So now we have monotherapy out to 96 weeks. We don't need to give this with entecavir or tenofovir. They have a high barrier to resistance. They're extremely potent. And again, cause both not only a surface antigen decline, but declines in e antigens and core-related antigens. The unique thing about these is because they're potent, they actually look to be much more potent than, say, tenofovir or entecavir, and that has provided the opportunity for kind of a second regulatory pathway for these types of molecules, where you can do a prospective head-to-head trial with, say, TDF, and based on viral endpoints of suppression or undetectability at week 48, FDA has said, at least preliminarily, that that would be a path to approval. So I think this is a molecule that we may see as more of a pure antiviral that could potentially be available sooner than maybe some other cure strategies, and is oral once a day and very convenient. I think I'm going to skip over these overviews just so we can hit these last two immunotherapeutic slides. So VRON 200 is a unique kind of immunotherapeutic. It uses a chimp adenovirus, 2 different vectors, that has not surface antigen in it, but core and polymerase from hepatitis B, and has a unique HSV, so herpes simplex virus D protein adjuvant, if you will, that is supposed to be further immunostimulatory or prevent immune exhaustion or invigorate the response to the vaccine, if you will. And so what you see is they did a cohort where they got the immunotherapeutic plus elbasiran and tobevart, so the siRNA and the monoclonal antibody against surface antigen. And what you see are really profound surface antigen changes. And in the vaccine cohorts, you even see 2 patients that achieved a functional cure, including one that only got a single dose of this vaccinal kind of immunotherapeutic. And you also see the really profound and very high levels of surface antigen decline pretty quickly with this combination. Okay, the last slide of agents. I want to come back to TLR8. We mentioned that ASOs probably have a dual mechanism of action that involves TLR8 agonism. There are small molecule standalone, selgantolimod, orally available, oral therapeutic that targets TLR8 and has been evaluated for chronic hepatitis B. So what I'll just show you here is the schematic of the surface antigen changes with 2 different doses, 3 milligrams or 1.5 milligrams, and e antigen negative or positive. You can see not huge surface antigen declines, really around maybe less than even a half log, but there are these occasional patients that seem to have dramatic responses to just this oral TLR8 agonist. And again, you do see surface antigen loss in a couple of patients in this study where it was given for 24 weeks. At 24 weeks off therapy, there were 2 essentially functional cures. This was a small study, but it was maintained in those 2 patients. And I allude to this because this may be an adjuvant that, say, given with siRNAs that don't have their intrinsic TLR8 activity, like we could see potentially combinations using this oral therapy with an siRNA. And there is an ACTG study that is now kind of enrolled and is ongoing in follow-up of looking at this in persons with HIV and chronic hepatitis B. So these are just some other notable posters from the recent liver conference. I won't go into any detail on these, but I do want to reinforce again that we're seeing Bepirovirsen now, that ASO that we talked about, into phase 3 studies that are ongoing. And there is this phase 2 study, head-to-head to tenofovir with the capsid and CAM inhibitor ALG-184 that may be an alternate path to approval again. So what are the conclusions? Currently, for treating persons with chronic hepatitis B therapy, our mainstay of therapy is to suppress the DNA level. This has positive impacts decreases liver inflammation, improves clinical outcomes, delays progression or stops progression to cirrhosis, and decreases HCC risk. Functional cure with just nucleoside therapy is rare. Novel therapeutics continue to evolve rapidly. High levels of functional cure have not been realized. It's 10% really in the largest trials we've seen. Quantitative surface antigen is predictive, lower is better at you start. And I think we're really getting a clear picture that some sort of immune modulation is going to be required to be highly successful, if you will. And then this just schematically kind of shows what that might look like. Okay, so we're going to come back to our post-test questions. So which hepatitis B test or disease stage parameter is not part of updated treatment guidelines? Again, the 2025 EASL or 2024 WHO. Hep B DNA, E antigen level, fibrosis stage or presence of cirrhosis, or ALT. Go ahead and submit your answers. And let's see how we're doing. Okay, so hopefully, all right, great. We saw a pretty big move there, I think, and almost 70% of you got this right. So E antigen is what has kind of been dropped. Previously, as we talked about, treatment guidelines relied on E antigen status to determine the hepatitis B DNA thresholds. And the most recent guidelines really just focus on the DNA level and have removed E antigen. You do still look at ALT and then certainly fibrosis or disease stage as other components that modify when you might start treatment. Okay. And here's our next post-test question. Which of the following is not included in functional cure of chronic hepatitis B infection? So which is not part of the definition of functional cure? Loss of surface antigen sustained for more than 6 months off therapy, loss of HBV DNA level or undetectable levels sustained for more than 6 months off therapy, clearance of HBV CCC DNA from hepatocytes, or undetectable E antigen levels. Go ahead. Okay, great. Over 80% of you got this right again. And so again, functional cure, we're really just looking at surface antigen DNA, and E antigen should be part of that, maintained for 6 months. The CCC DNA, as we talked about, would be part potentially of a sterilizing cure approach, but really not where the current efforts are focused. And with that, I think we're ready for question and answer. So let me stop sharing.
Thanks, David. Really outstanding talk, as usual. So I do want to make just a couple of reminders as we take these questions in the last several minutes. We can only answer the questions if those that are in the Q&A, if you have your full name and institution. Sorry, that's just a policy issue. So there are several questions in the Q&A, but please just resubmit them or update them with your name and institution. And so while we're waiting for that, David, I thought maybe the way we could divide up these questions is first by management of kind of chronic hepatitis B, and then maybe we can talk about novel diagnostics and also novel therapies.
Sure.
And so one question, to the point that you had just made about the changing guidelines, um, I think it'd be really interesting to kind of hear your approach to how you follow somebody who would traditionally fall within kind of the gray zone of the WASLD 2018 guidelines as we're waiting for the update. So this is a person whose HBV DNA is greater than 2000. They are E antigen positive, and but they don't have an elevated ALT, but they may have some other risk factors, like maybe a family history of HCC. How would
Yeah.
you approach that?
Yeah. I think it's a great question. And I think we're still kind of learning how to interpret the new guidelines and with some of these gray zone cases. One, I would certainly want to get some other type of fibrosis staging. If folks have access to elastography of some sort, that would be the next step I would take to have another point, kind of another piece of information. But assuming they don't have moderate to advanced fibrosis, where maybe again that's a more cut and dry, it's typically I've started doing more of a shared decision making with my patients. I think it goes into, how old they are, if they're on a lot of other medications already, or what their comfort level is or hesitancy to start another medication. Because I think part of the discussion is also I usually talk to them and say, once we decide to start this, typically you're going to be on this indefinitely, maybe the rest of your life, or until we have better therapies. And I've actually been a bit surprised, but I actually encounter a fair bit of hesitancy for people to start, especially my folks from either sub-Saharan Africa or Southeast Asia who are in their 30s or 40s. They usually actually are fairly hesitant, and then we just talk about, well, okay, let's make sure we repeat your testing every 6 months at least and get repeat fibrosis assessments annually.
Great, thank you. And I think one of the nicest sentences I've heard actually from another friend and colleague was Susanna Nagy during another presentation, which is that, I think these evolving guidelines just give you a permission to treat. Whereas before, I think we felt like we could be very regimented. Well, you definitely can't treat. But I think we have a little bit more permission, and I really like that. So I think on that vein, with regards to management, so this is a pre-sent question from Dr. McGrady at looks like anthc.org. How do you follow HBV? What are your recommendations for following HBV DNA after surface antigen seroconversion in those lucky ones?
After surface antigen seroconversion, so they've lost surface antigen and are now surface antibody positive. So I wouldn't routinely follow DNA very often. I think I would document once when if they had conversion that the DNA should be and is undetectable. If we're talking about a person that's not living with HIV, I don't think there's any necessarily routine reason to be rechecking HBV DNAs, barring, profound immunosuppression, something like that, chemotherapy, or B cell depleting therapies is a whole different population. In persons with HIV, if they had that conversion, it would probably really be the same scenario. There's really no reason to be repeating hepatitis B DNAs, but we could have a larger discussion about if they're going off antiretroviral therapy onto something that doesn't also have Hep B activity.
Excellent. And I think for a couple of other questions from before, from Jennifer Dunn from Children's Colorado, as well as Dr. Carlo from BHCHP, can you address how HIV co-infection kind of impacts treatment and outcomes?
Yeah, sure. So treatment, I guess in one way we're kind of lucky. Our modern antiretroviral regimens, our first-line regimens, kind of have built-in hepatitis B therapy. And as you notice in those guidelines, persons living with HIV are one of the groups that are called out that should be treated for their hepatitis B regardless of anything else. So when you're treating their HIV, you're going to treat their hepatitis B. In terms of disease progression, certainly there is some evidence, certainly very potent antiretroviral therapy that was very potent for hepatitis B, that there was a faster progression of liver-related events in persons living with HIV and hepatitis B together, similar to seen with hepatitis C as well, probably related to a lot of different, more inflammation, different effects of HIV in stimulating TGF-beta and things like that Ray Chung has really looked at. But ultimately, treatment kind of takes care of itself. We just need to be vigilant about persons with chronic hepatitis B to not forget to monitor their DNAs. I think that's what sometimes can get lost, is we focus on their HIV RNAs, but forget we should be at least checking DNAs periodically, roughly every time you're checking an RNA, I would say. And then don't forget about HCC screening. I think that's the other big one that sometimes can get forgotten.
Great, thank you. And so I think our last of the questions around chronic management, I'm going to ask you one, and then we'll also ask in the same question another one from Dr. Yao from the Mayo Clinic. But mine is, how are you factoring in quantitative hepatitis B surface antigen into your management decisions, number one? And then to address Dr. Yao's question, are you using hepatitis B core related antigen?
Yeah. So yeah, I think surface antigen is something I use occasionally, primarily for the patients I happen to follow that have chronic hepatitis B mono infection, so they're not living with HIV. And are younger, don't have evidence of advanced fibrosis on elastography if we've done that, and maybe have expressed some interest to considering stopping, or so essentially looking at, would I consider them for nucleoside cessation? There's certainly data that less than, if patients have a quantitative surface antigen less than 100, they're significantly more likely to have a durable response off nucleosides, and maybe even some of those will actually flip to a functional cure phenotype. So I would consider it. Again, the caveat would be that they don't already have advanced fibrosis or cirrhosis. That would not be a population I would consider that in. And then that threshold actually varies depending on their race or ethnicity. We know Caucasians or white patients tend to respond a little better than, say, Asian patients, where maybe the threshold should be somewhat different. So that's where I look at it. I have not been using hepatitis B core-related antigen at all currently in my clinical practice. I do think it's obviously been a component of a lot of cure studies. It probably looks to be one of the better antigen markers, at least compared to HBV RNA, I would say, especially for things like CAMs. But I haven't routinely been using it in clinical practice. To be honest, I don't even know if you can commercially get a core-related antigen. You can get quantitative surface antigen.
Thanks. And so maybe one more question on management, because I know this comes up. This is from Dr. Arnold Liu from before, and the question is around the significance of the Hep B core antibody positivity. And maybe to just review what that means in terms of kind of latent reservoirs. And then my question to you is, how are you managing those patients with HIV who are core antibody positive who might be going on a long-acting injectable?
Yeah, yeah. Yeah, so as we talked about, kind of typically anyway, a marker of prior infection. I do think, for persons with HIV, they're often on Hep B therapy anyway. So checking a DNA once they've come to clinical attention, whether that's of any use or not. But I think it really is very important for those that then are going to consider maybe a long-acting injectable, for HIV, which does not have any built-in hepatitis B therapy, if you will. So I think one of the crucial things is to be checking surface antibodies in these patients. And if they're isolated core positive, the recommendations, the DHH's guidelines would be, and presuming they're surface antigen negative and DNA negative, would be to giving them a dose of vaccine and seeing if they respond. And essentially remembering or doing anything you can to get a surface antibody titer that's above 10, the higher the better, before you consider maybe going to a tenofovir sparing HIV regimen. That's not absolutely required, I would say, in somebody who's isolated core positive, even if they don't develop surface antibody, that they can't go on an HIV regimen without tenofovir. But the other part I try to do is always have that listed as one of my problems in the notes when I see them, isolated hepatitis B core positive. So there's a reminder there, hopefully, when folks look. Because I do think what we have to be vigilant of then is if something seems amiss, the transaminases are coming up or something changes, to be thinking about looking for hepatitis B reactivation. I guess I don't have a set cadence where I would automatically check for reactivation, like check a surface antigen or a DNA, but I think that's another consideration.
Thanks. Thanks, David. And really, I think when you look at some of the data, especially some of the US data, particularly coming out of the VA, it looked like the risk of reactivation was really only around 1%, but much higher if you had prior surface antigen positivity somewhere in the medical record. So, certainly one of the questions that I think we get asked a lot. So thanks for bringing that up also, Ms. Fuller from the Thrive Partnership. Okay, well, in the last couple of minutes, let's transition to kind of some of the novel therapeutics and questions around there. This question is from Dr. Leonard Sowa from the NIH. In the IMPROVE-2 study that you discussed, how many doses of nivolumab were given? And were there any immune-related AEs in the study? That was my
Yeah,
question too, Leonard.
yeah. Only there was only one was generally given. There was an option based on the responses to kind of use a response-guided therapy and potentially do a second dose, but I don't believe anybody in that trial actually got 2 doses. But as the protocol was written, there was this provision if there was certain responses and parameters that you saw a further decrease that you could do a second dose. But I don't believe any were given a second dose. And it is a low dose of nivolumab as well, kind of compared to what we think of using for other, oncology indications and things like that. They were screened definitely for things like thyroid antibodies and things like that, is my recollection, and so kind of eliminated somebody that maybe would have had a higher risk. I don't recall any specific AEs, certainly no immunologic AEs related to nivolumab, but to be sure, I'd have to look back at the study in detail.
Thanks,
Leonard,
Dave.
always ask the tough questions.
That's why he's at the NIH. So, I- so David, I have a question for you. Why do you think at least the first generation of ASOs seem to be more potent than the siRNAs?
Yeah, I do think a lot of it is probably due to TLR8 activity as well. Um, you know, and as we talked about, they really don't get into hepatocytes nearly as well, but I think it's that, resident macrophages, Kupffer cells, hepatic sinusoidal epithelial cells, and getting in there and causing maybe even a local immune response that's perhaps somewhat beneficial. As I mentioned, the next generation, they really now have developed in vitro kind of screening assays to look at TLR8 activity and are tweaking to try to optimize, readouts on TLR8 assays from in vitro models in terms of, modifying side chains or changing the kind of ends of the ASOs. So I think that's probably what it is. It obviously is more frequently dosed, which could be a positive or a negative, whether that any just the frequency of dosing has anything to do with it. I don't know, and I think this point's been made before. These are really generally pretty small studies with small ends. So uh, I like to sometimes step out on a limb and make guesses, and that's probably all they really are. But we could see changes for sure.
We'll take those guesses. And then I guess my final question, maybe around the novel agents, is we know that in HIV, persons with HIV and hepatitis B, in at least a cohort of patients, probably those with lower CD4 counts, tend to have higher rates of functional cure. And they also, over time, because they tend to be the cohort that has been treated the longest for hepatitis B, both with kind of these considerations of a higher functional cure rate and probably lower quant S values. How do you see them fitting into into the landscape of hepatitis B novel therapeutics? And I say this because many people on our webinar, um, are clinicians who may be considering novel therapies in general for their patients.
Yeah, I think that's tough to know. I think one, I think it's very interesting that we do have that phenomenon, right? And presumably, I guess my thought about it is somehow their immune system was set up to handle Hep B, and it just wasn't able to do it at the initial time because they had such advanced HIV. And once we intervene and kind of take care of that, whatever there is that we certainly don't understand yet about their immune makeup allows them to kind of step in and have a more vigorous response. I think going forward, it just presents challenges, and you know this better than I do, Debika, in terms of enrolling into studies, because we are seeing maybe a little bit surprisingly low levels of surface antigen in these patients, different than persons that just are living with hepatitis B. And again, I think presumably that's because those persons with chronic hepatitis B, the ones that would have functionally cured, kind of sorted out a long time ago, and these persons living with HIV have been more recent. In some ways, you could say, well, they have low surface antigen. Maybe they're a key population to look at cure, and actually maybe could prioritize some of those because we don't really have the data yet to know if persons living with HIV who have low baseline surface antigen are going to have that same kind of beneficial effect and response with novel therapeutics. But my hypothesis would be they would. So maybe even that's a population we prioritize.
You're preaching to the choir.
Yeah,
Agreed.
right.
All right. Well, I think we are almost at time. I know there are some final slides that we will have up. So thank you again, everybody, for a really wonderful discussion. Thank you, Dr. Wyles, for a fantastic presentation. Evaluations, information on how to claim CME will be emailed by 5 p.m. Pacific time tomorrow. And if you're not receiving our emails, please just check the frequently answered questions section on the IAS-USA website. We want to also highlight some future programs. There is the podcast hosted by Michael Sag, which is Going Antiviral, which will be about GLP-1 receptor agonists with Dr. Darcy Wooten. That should be very interesting. There is also going to be an HIV 101, Foundations of Management of People Who Are Newly Diagnosed with HIV. That'll be Thursday, September 25th. And then I think very interestingly, a conference on bacteriophages in DC from October 12th through the 14th, which will be an in-person event. And then also a reminder that there is the IAS-USA annual update on HIV management. It's going to be held in Chicago on November 18th, 2025. All really very exciting programs. And a reminder also for the virtual course that will be held in DC. Thank you, everybody.
Thanks. Bye.